So Mr. Naggar is one of our consultant obstetrician gynecologists, and he's part of the endometriosis team as well. Welcome to the shop floor, Ahmed. Really appreciate your contribution. Dr. Naggar has got extensive experience in the field of advanced laparoscopy as well as medical education. And again, his contribution is greatly valued. Thank you so much for presenting. Over to you.
Thank you. Thank you for the introduction. I've been asked just to present today for the medical management of endometriosis current and new modalities on horizon. And just 1 second. And as we know, that endometriosis is quite a big problem, and usually the main problem that we suffer with endometriosis, usually the pain and subfertility issue that presented to the gynae clinic. And we know that the pain usually, it's 3 types of pain that we know: nociceptive pain, neuropathic pain, and then nociplastic pain. And probably this will be addressed with slides with the anesthetist about this. And we know that the pain with endometriosis started with the tissue damage due to direct infiltration or due to the inflammatory response due to the cytokine release. And then with the progression of the disease, this nerve will become damaged. And after this nerve become damaged, you have chronic neuropathic pain. And after that, it starts to nociplastic pain, which may cause what we call central hypersensitization syndrome, where you have your brain start to adapt and there is decrease of inhibition of incoming signals and increased sensitivity of the incoming signals, which makes the pain much more worse. Right, so actually what happening, we need to think, out of the box when we presented with the cases of chronic pelvic pain in our clinic. It's not only endometriosis, because we have what's called the EVIL quadruplets, where you have the interstitial cystitis as a cause of pain, irritable bowel syndrome, and pelvic floor tension myalgia. And it's quite common that you have overlapping between the symptom of endometriosis and the other types of this EVIL quadruplets. And usually you may need to treat more than one condition at the same time. I'm going to concentrate now on the medical pharmacological treatment that we do as a gynecologist, and it's mainly the hormonal treatment, what our current practice and what the future for it. As you know, that the indication for the medical treatment is mainly to reduce pain, improve fertility, and delay recurrence as long as possible. And usually we could use it as an empiric treatment, or use it as a prevention for recurrence after surgery, or for this patient who are not desiring surgery because of the not accepting the complication of the surgery, or recurrence after complete excision in the first surgery, and the first surgery was quite difficult, complicated, and you don't want to go back again, or as a combination between surgical and medical treatment for the patient. Possibly the analgesic will be discussed with anesthetist about this. Regarding the hormonal treatment that we have for the time being, the initial thing that we usually use is combined oral contraceptive pills, and usually the low estrogen progesterone combined oral contraceptive pills is the first line of management that we can use. And usually we found in a lot of studies that extended regimen, which including 12 weeks, 84-day extended regimen, was 20 microgram ethinyl estradiol and 90 microgram of levonorgestrel with 1 week free interval, will give a better control than in controlling of dysmenorrhea rather than the 3-week cyclic regimen. And now there is more recent development with using flexible extended low estrogen progesterone product, which having 20 microgram of ethinyl estradiol and 3 milligram of drospirenone, and use it for 120 days consecutively. So you use it and then give an interval of 3 days of 3 tablets and continue. And this give even more better control if the patient is not responding to the extended regimen. And we have, I think in the UK, that we have Eline is one of these products that they have, the only product that they have 20 microgram of ethinyl estradiol with drospirenone. One of the problem with this is the low dose of estrogen causing sometimes quite a lot of breakthrough bleeding, and you may need to increase the dose to one of the combinations that have 30 microgram of ethinyl estradiol rather than 20 microgram. Progestin is the second mainstay treatment for endometriosis, and usually there is different mechanisms that progesterone working to treat the pain with endometriosis, including ovarian suppression, effect on the endometrial morphology by causing destigmatization, atrophy, and alteration in the steroid receptor ligand binding. Also, it have immunomodulatory suppressive effect on the local inflammatory products from the ectopic endometriotic tissue, including interleukin-8. They also decreasing the angiogenesis, which is one of the major histopathological formation that we find in the active endometriotic lesion, and also have a direct effect on the nerve fiber density. Most of the studies that have been done on progesterone show that progesterone is effective in treatment of pain associated with endometriosis. Is improvement reported to be between 60 and 94%. There's different and variable types of progesterone in the market that you can use, including the northestrone acetate, and usually most of the studies use doses between 2.5 to 5 milligram per day. These are just 75 microgram per day, and you can increase it and double it if the patient is not responding to 150 microgram per day, which sometimes give a better pain response. Dihydrogesterone could be used also 10 to 30 milligram, and this is possibly the only medication on progesterone that probably doesn't affect the conception. So it could be used for those ladies who want to get pregnant with no effect. To be honest, northestrone acetate is not licensed as a contraceptive pill. However, the probability to get pregnant with it is about 5% or less. So because it causes atrophy of the endometrium, very unlikely to get pregnant. However, dihydrogesterone, if you use it between doses 10 to 30 milligram per day, unlikely to affect the ability to conceive. However, it's quite weak medication, and usually the response is not that very good as the other medication. Depo-Provera injection, you could use it 150 milligram injection every 3 months, and it gives a good ovarian suppression and some sort of improved response. However, the side effect of it, including breakthrough bleeding, weight gain in 2 years' time, and sometimes also affecting the bone density after 2 years of use, may have some sort of limitation. Gynaecologist, this is probably the only medication that licensed specifically for progesterone for treatment of endometriosis. Not very commonly we use it in the UK, although it's much more common to be used in European countries for the time being, and usually can give a dose 2 milligram per day, and if no response, you could increase to 4 milligram per day. One of the main side effects of this medication, that 80% of the patient in the first 3 months have quite irregular bleeding, and they may stop it because of this. However, after 3 months, this pattern of bleeding is improving, and only 30 to 40% will have these problems. About 60, 70% will have a good response after this. And also we found that after use of 52 weeks, which is about a year, there's some sort of affection of the bone marrow density. Subcutaneous implant, in the term of implanon, also could be used for treatment of endometriosis-related pain. Levonorgestrel also quite effective, especially if there is associated adenomyosis, and sometimes combination of levonorgestrel with GnRH analog for treatment of adenomyosis give a better effect than levonorgestrel alone. Modalities acetate oral tablet can be used, but usually a bit higher doses than normal, 30 to 60 milligram per day. And ciprotron acetate 10 milligram per day, which is under the name of Androcure, could be used. However, this 10 milligram is not present, I think, in the UK market. It's only 50 and 100 milligrams. So unfortunately, it's much more in North America. When also you prescribe progesterone, probably you need to be aware of any any problem with the patient. So this patient that they have disturbed lipid carbohydrate metabolism, C19 progesterone derivative like northestrone acetate will not be more suitable. You could use something like C17, and also the derivative like Depo-Provera, and also C17 has more effect on the mood swing and depression. So if the patient has more mood swing and depression, which is quite common in the endometriosis patient, so preferably to avoid them. One of the major problems that we see with progesterone treatment is progesterone resistance in women with endometriosis, and quite presumed, different mechanism depending on the epigenetics, hormonal imbalance with increased estrogen to progesterone, also at the level of the receptor, because we have 2 types of progesterone receptor, A and B receptor, and we know that progesterone A receptor is less efficient in executing the act of the progesterone, and progesterone B is the main one. That's why for a lot of patients, probably at the molecular level, they have increased number of progesterone A in relation to progesterone B. So there's quite a lot of some sort of mechanism that causing the progesterone resistance. This is one of the major problems that we find when we're treating patients with progesterone and not responding to it. And actually, to manage this progesterone resistance, there is some sort of assumption and some sort of recommendation of shifting to Gynaecologist, because this is the only medication that I've extensively studied specifically as a progesterone treatment for endometriosis. And I advise using with a higher dose, like 4 milligram. You can switch to other types, so the patient not responding, to the subcutaneous implant using levonorgestrel IUCD, or using medroxyprogesterone acetate or injection, so using different type. Or change the route of administration from oral to intramuscular to IUD. Using selective progesterone receptor modulator, some studies has been done about mifepristone, and it showed good effect for this patient who are not responding to the normal progesterone medication, but usually the dose is quite small. It's 2.5 milligram, 5 milligram, or maximum 10 milligram. Unfortunately, you don't have this also in the UK market. It's North America, and this some randomized controlled trial showed a superiority of using mifepristone 5 milligram per day for those ladies who have progesterone resistance. You can use some combination of non-steroidal anti-inflammatory and progesterone, which gives some sort of better effect. Some other studies about using antioxidant medication like N-acetylcysteine, which is one of the mucolytic for this patient that they showing no response to the progesterone or tyrosine kinase inhibitor, which is some studies has been done in fertility sterility in 2017, as you could see here. Actually, there is some sort of future research going on moving beyond the macroscopic disease picture, and future therapeutic development lead to consider the molecular phenotype when we examine the endometriotic tissue that we remove under microscopy, just to detect the molecular phenotype of this endometriotic lesion and detect the type of the receptor with immune histochemistry to decide the best drug to be used. There's quite a lot of studies going on for the time being for this. Other medication that used for endometriosis, danazol, which is past history now. It's popular medication in the 1970s and 80s, and usually the route of oral 200 milligram TDS for initial 3 months. However, due to its androgenic side effect, significantly declined in the last 20 years of use, and there is several randomized controlled trials compared its efficacy to other hormonal treatment. It was a good effect. They used also sometimes combined therapy of using 50 milligram to reduce the side effect instead of using 200 milligram was combined oral contraceptive pills and showed a better improvement for dysmenorrhea. And also some studies done about vaginal administration to reduce the side effect to the minimum using 100 milligram daily to 200 milligram vaginally showed improvement in the pain score for those who suffer from deep endometriosis, especially when being combined with using a Mirena coil. Aromatase inhibitor like letrozole 2.5 milligram per day or anastrozole 1 milligram per day also showed some sort of improving response for those patients who have a bit of a resistance to take the medication, especially if combined with other medication like GnRH or northisterone acetate. GnRH agonist and antagonist is also one of the mainstay of the treatment for endometriosis, and we know the GnRH analog is liproyl acetate like Prostab with add-back hormone, HRT, like Tibolone could be used. And usually it's licensed for 6 months because it's effective the bone marrow density. However, you can use it up to a couple of years with add-back HRT, and then you can give a little bit of few months of break. You can check the bone density at that point of time if you have any concern, and then start another course after this. The level of the E2, usually there is different forms of GnRH agonists. It could be used as an injection, and there is some sort of nasal spray like nafarelin, which could be used between 400 to 800 microgram every day. And usually there is a level of E2 need to keep the bone protected. And they've done a lot of studies, and they found that if you have a level of estrogen between 30 and 50 picogram per ml, this level is sufficient enough to reduce the growth of endometriosis and treat it without marked affection of the bone. When you use the injection like Prostab injection, usually we found that the average amount is about 14 picogram per ml. That's why it's affecting the bone. But they found the nasal spray, usually the average level is 41 picogram per ml, which may be a better use for those ladies, especially if they any concern about their bone marrow density. Regarding the GnRH antagonist, it's not licensed in the UK for the time being, although one of them is licensed the last year. There is 2 types, Elazolex and Linzajolex. And actually, Linzajolex is licensed in the UK since June 2022 and in the European countries with a dose 100 milligram and 200 milligram, but it's mainly licensed for treatment of mild to moderate symptoms of fibroid, not for an endometriosis. However, it could be used. Elazolex has been approved by the FDA. In North America has been used, not approved yet in Europe or the UK. And usually there is 2 regimens for using Elazolex, which is a very common medication now to be used in North America. Low dose 150 milligram per day, or the high dose, which is 200 milligram twice a day. Usually you found the level of estrogen in the low dose regimen 41. That's why it's licensed for 2 years, because it doesn't affect the bone density as the high dose, which is the level of estrogen 12 picogram per ml. However, the response to the pain, including dysmenorrhea, dyspareunia, is much better when you use the high dose regimen, which is only licensed for 6 months. Currently, there is oral administrated GnRH agonist in phase 2 trial. and probably we may hear soon about approval for it by FDA. Usually there is some sort of advantage of using the antagonist in relation to the agonist because we don't have a flare-up effect as we see it in the agonist. It's effective usually within an hour of administration, doesn't take 7 to 10 days at the agonist. Usually also there is a rapid predictable recovery of pituitary gonadal axis resulting in prompt restoration of menstruation ovulation, especially for those young ladies who wanted to control the pain for a short time and then wanted to try to get pregnant. So it's much better to use the antagonist than the agonist. It's also used in an oral form. Agonist, unfortunately, there is no oral form for the time being, although some studies now going on to get approval for it. If we looked for the endometriosis guidelines regarding the medical treatment, we have quite a lot of guidelines, international and national. We have about 7 international guidelines, including the H3 guidelines, the Australian one, and the European one. And also we have about national guidelines in Malaysia, Korea, India, France, everywhere, about 20 of them. So if we look for the medical treatment for endometriosis-associated pain, like the French guidelines recommend not to start empiric treatment unless you have a surgical confirmation or histological confirmation of endometriosis. And this is what we not follow for the time being, because NICE guidelines, you could start empiric treatment. H3 NICE, Malaysian, Korean, Indian, and Turkish guidelines recommend empirical treatment. And usually the first line is oral contraceptive pill, progesterone for treatment of pain due to presumed endometriosis. The American College of Obstetrician and Gynecologists recommend also empiric treatment, and also they going to using the GnRH analog as a first line of treatment as a therapeutic and diagnostic modality for 3 months for empiric treatment, rather than to be second or third line. There is an overall agreement that medical treatment using combined contraceptive pills, progesterone, GnRH, agonist or antagonist can be used for treatment of pain associated with endometriosis. If we look at these guidelines, danazol is mentioned in some of them, like the French, Korean, Indian, and Turkish guideline, without clearly endorsing its use due to its side effect. But other guidelines, like the H3 NICE, doesn't make any recommendation regarding it. It's never mentioned in them. The Asian, Turkish, and Malaysian guidelines state the aromatase inhibitor. They have a limited place in treatment of pain related to endometriosis, and I think usually it's used in combination with other medication when the patient not responding to this medication, other hormonal treatment. So it's usually an add-up medication rather than to be a sole treatment for endometriosis. Regarding management of endometriosis-associated infertility, I think Jay has covered it, but quickly, all published guidelines recommend against use of hormonal therapies if the patient wishes to get pregnant, which is quite sensible anyway, because most of them are contraceptive. The French, H3, German, Indian, Korean, and South African and Turkish guidelines recommend surgical treatment of endometriosis, particularly for early endometriosis, to improve spontaneous pregnancy rate. ECOG guidelines suggested that the surgery improved pregnancy rate, although the magnitude of improvement is not clear. Some guidelines indicate that the benefits of the surgery to improve fertility in women with deep endometriosis not well established, although some low-quality studies from France now, 2 of them said that it's improving it by about 50%, as Jay indicate. The overall agreement that in the infertile women who had a previous surgery, assisted reproductive technology are better than the repeat surgery. And most guidelines advise against surgical treatment of endometrioma prior to ART to improve pregnancy rate. You may need to treat to remove it just to improve the access and reduce the risk of pelvic infection, as Jay indicating in his slides. So the last few slides about update for medical management. There is some sort of a lot of studies going now, most of them coming from Scotland, about using the medical treatment instead of the surgical treatment. And there is ESPRED-2 study done by Professor Andrew Horn from Edinburgh, about the multi-center randomized controlled trial to determine the effectiveness of laparoscopic removal of isolated superficial peritoneal endometriosis versus the medical management. And also there is another study by Justin Clark in Birmingham, randomized controlled trial to treat deep endometriosis surgically versus hormonal treatment. And they're still in phase 1 and phase 2, I think. So we still, I think they even still recruiting, yeah. One of the major issues is recurrent endometriosis. That we know that quite a lot of patients have coming with a recurrence. So we know that about 20% of the patient coming after 2 years, sometimes with the recurrence of their symptoms and about 40% after surgery may coming with the same symptoms after 5 years. And they done some sort of a big survey on about 18,000 Scottish women about they have endometriosis, and they found that they have a repeat surgery, about 2 out of 3 of them within 2 years, and 40% of them have more than 2 operations, and 25%, quarter of them ending by having hysterectomy and bilateral symphyngectomy to control the pain at the end, which is quite a significant number, especially for young ladies. That's why I think there is some sort of study also going on now about preventing recurrence of endometriosis by means of long-acting progesterone therapy. And this is preempt study. I think it's comparing using long-acting progesterone like Mirena or depo-pyrrolate progesterone acetate versus combined oral contraceptive pills after surgery to prevent recurrence. And also another study, recurrence of endometriosis long-term GnRH analog versus repeat laparoscopic surgery, is also started to recruit in Aberdeen. There's also a lot of studies now trialing a lot of medication, including medication that targeting reducing the angiogenesis, or using melatonin as an antioxidant anti-inflammatory effect, or using dopamine receptor agonists like quinaglide or cabergoline to treat endometriosis, or using even green tea because it has an anti-angiogenic effect to treat endometriosis. All of this trial is still in phase 1 and phase 2, and all of this is the number of them on the randomized controlled trial registry. Thank you.
Thanks, Ahmed, for a very comprehensive talk supported by data and studies, and it has covered almost every aspect of the hormonal treatment that we use, and those which will be potentially usable in the near future. So the floor is open for some questions. How much time do we have, Subul?
We've got time, Prof. So next presentation will be Madan's, but yes, I think thank you, Ahmed. You really saved us there with your presentation and your timings. We've got 3 minutes, and then we'll be starting the new. So we've got a question, Ahmed, is about the fact that the usage of GnRH agonists. Have you used norethisterone? I'm guessing, is this question a general question, Dr. Chaudhry? I'm guessing it is.
Hi, sorry. The question is, have you ever used GnRH agonist? Sorry, first of all, brilliant presentation. It's really, really brilliant. With GnRH agonist, have you ever used only norethisterone only at back without adding progesterone into it? And what's your take on that?
Yeah, it's very interesting actually, because the first initial studies using add-back hormones GnRH are mainly based on using northisterone, which is the comparable for northisterone. So you can use it. Personally, I haven't used it, but you can use it because this is the first study has been done as an add-back hormone with the GnRH using northisterone or northisterone. So you can use it, yeah.
So that's without using concurrent estrogen along with it?
Yeah, you can.
Okay, thank you.
All right. And can you please repeat the dose of the progestogen that was used in the treatment of women?
It's dihydrogesterone, and it's usually 10 to 30 milligrams. Yeah.
Thank you.